Okay, guys, video number 2. So we left off talking about chest wall restrictions. Now we're going to talk about pleural abnormalities. All right, when we think about pleural, we want to think about the pleural space. Okay, so remember we have our lungs. All right, here's the bronchi and the lungs. And then you have the chest wall. I'm exaggerating. And in between, you have the pleural space. This pleural space helps contribute to negative pressure, which is going to kind of pull out with the lungs so that it helps to prevent collapse. So if we have abnormalities to anything in the pleural space, then potentially the lungs will collapse back on each other because that negative pressure has been disrupted. So we'll kick it off with pneumothorax. So what happens when someone has a pneumothorax? They have air in the pleural space. And usually this can be caused by a rupture of the visceral pleura or the parietal pleura, or can be a rupture to the chest wall itself. So what is that going to happen? That's going to change negative pressure in the pleural space. And so you'll lose recoil. Okay. And if you lose recoil of the lungs, that's going to disrupt those recoil forces, and then the lungs will collapse. Causes of this could be something simple, like a chest trauma. It could be the rupture of something called a bleb, which can occur with emphysema. Sometimes with emphysema, when in the alveoli, you get kind of outpocketings. Those outpocketings are called blebs, which come as a result usually of air trapping in the alveoli because they've become kind of overstretched and deteriorated. Pneumothorax can also be caused by mechanical ventilation sometimes, or by a needle aspiration. If someone's doing a thoracocentesis to kind of withdraw fluid out of the lungs for any number of reasons, which some of them we'll talk about, in doing so, you might wind up damaging that negative pressure space, and then that has to be corrected. There are 2 different types. You can have an open pneumothorax, which means literally open to the outside world, that it can go right through the chest wall. So now you're going to disrupt that space because air is going to go from higher concentration here to lower concentration here. Air will flow out, the lungs will collapse. Or a tension pneumothorax, which is life-threatening. When someone has a tension pneumothorax, what that means to us is that air escapes from the pleural cavity from the bronchus, and then you can't really have any airflow properly through the system. The signs and symptoms obviously would be pain, tachycardia, and then dyspnea. You'd have difficulty breathing as well. The treatment for it is to aspirate, allow for some suction, to reestablish that negative pressure space and allow whatever wound we have, whatever rupture we have to heal. Okay. Second issue with the pleura is pleural effusion. Okay. Okay, so when someone has pleural effusion, that means they have the presence of fluid in the pleural space. Now remember, that's not supposed to be. There's supposed to be air in the pleural space. Okay, usually this fluid comes from either a blood vessel that's ruptured or lymphatic vessels. It can be the accumulated of lymphatic fluid in the pleural space. Small collections of fluid may not be detectable at all. But remember, this is not fluid in the lung proper. That's going to be something different. The reason that the lymphatic capillaries and vessels are of particular importance here is around your lungs you have a very dense network of lymphatic vessels. What can cause pleural effusion? You can have injury, but very often it's due to infection. Inflammation inflammation is going to increase the flow of fluid to an area, which we've talked about extensively. And then any cardiovascular issue that will raise pulmonary pressure. If you're raising pulmonary pressure, there is an opportunity then to have hypertension in the pulmonary system, which can rupture some of those pulmonary capillaries. How is it diagnosed? It's diagnosed through chest x-ray and then thoracocentesis or needle aspiration to see where the fluid is, and then remove that fluid so that we can reestablish the appropriate amount of pressure in the pleural space. Okay, sometimes it's not fluid that's in the pleural space, blood or lymphatic fluid, but sometimes it's pus. Okay, so if you have pus accumulating in the pleural space. Okay, so how can that happen? So usually that's due to an outpouring of lymphatic fluid that can develop as a sidebar to things like pneumonia or infection. Or sometimes surgery. So now instead of having fluid, we have pus in the pleural space. Obviously, you're going to have things like pain, pleuritic pain, fever if it's infectious. Can have tachycardia, which again would be compensatory. Cough. The treatment for this is depending on what the problem is. But if it's a bacterial issue, it would be antibiotics and then drainage of the fluid. Okay. So those are some issues associated with the pleural space. Now we're going to talk about some restrictive lung issues. So again, now we're going to move a little bit deeper and talk about things in the lung proper. So something that is restrictive lung diseases would mean for us that there's been a decrease in compliance, and that will require for us more effort to breathe. So what does it mean? What do we mean by compliance? Okay, your lungs are stretchy, and that stretchiness is what we mean by compliance. Why is it stretchy or compliance? Because of the presence of the protein elastin. This protein allows for, just like you have elastin in your skin, this is going to allow for the lungs to expand and stretch a bit, not overstretch, but stretch a bit. And that's what makes them compliant. When you have a loss of compliance, that equals to me that it requires more effort to breathe. More effort to ventilate your lungs. So we don't want to lose compliance. This would be characterized by things like difficulty breathing, an increased respiratory rate, which again, a decreased respiratory rate, that's going to be compensatory, and a decreased tidal volume. Okay, so some of the things that are classified as restrictive lung disease. The first one is when someone has aspiration. Okay, when someone aspirates, it means that they have the passage of either fluid or solid particles into the lung. This can occur for any number of reasons. It could be something like abnormal swallowing. We've all experienced that. Right? Obviously, this is not a disease state, but if someone, for example, is talking when they're drinking, and then they have fluid go into their throat or their trachea, again, maybe not all the way into the lung, they wind up coughing. Okay, so you can have a defect in your swallowing mechanism or abnormal swallowing, but in this case, now we're going all the way into the lungs with either the food or the fluid. Okay, who does this happen to often? People under sedation. People with seizure disorders. And sometimes people have had a stroke. if that stroke impacts the area of the brain that's working to controlling swallowing. In addition, substance abuse. Okay, so when again, things like alcohol and certain types of drugs that can depress the central nervous system might disrupt the swallowing reflex. Okay, how do we know that this has happened to us? You would have an onset of choking, of course. But if it goes down into the lungs, okay, wheezing, intractable coughing, what you are at risk for with aspiration is aspirational pneumonia. So something makes its way down into their lungs, there's bacteria associated with it, and now you have aspirational pneumonia. The treatment for aspiration is going to depend on what's causing it in the first place. Is it something to do with the swallowing reflex? There's a seizure disorder? Is it sedation? Depends. Okay. Atelectasis. So this is a collapsed lung. Okay, so when we think about what's really required to prevent lung collapse, we can identify then the thing that's gone wrong when we have lung collapse. So for example, remember you have three things that prevent collapse. And this is stuff you probably talked about in AMP2 when you talked about the respiratory system. So if we have three things to help prevent lungs from collapsing, then one or more than one of those three things could potentially go wrong that would then cause our lungs to collapse. So, for example, thing number one, you had residual volume. There was always a set amount of air, a volume of air in your lung that would prevent collapse. If somehow that was compromised, then the lungs would collapse. Okay, you had negative pressure in the pleural space, okay? Or intrapleural pressure. So again, if you had something like a pneumothorax that would compromise intrapleural pressure, that's going to disrupt that negative pressure space, that could cause lung collapse. Or, remember we needed surfactant to help prevent lung collapse. If someone had a decrease in production of pulmonary surfactant, then their lungs could collapse. Collapsed lung can often occur post-surgically. Treatment for collapsed lung is deep breathing and position changes. Okay, and again, it depends on what's causing the problem in the first place. If somebody has a loss of residual volume in their lungs, so for example, if they're hypoventilated, is someone got a change in intrapleural pressure? Is it a pneumothorax? Or is it a decreased surfactant production? This issue is what occurs in premature babies. Babies born prematurely oftentimes don't produce enough of their own pulmonary surfactant. So what happens is as soon as they try to take their first breath of air, that because they don't have surfactant, their lungs do collapse. So then obviously you would want to ventilate. And then we'd want to try to come up with a way to get surfactant production turned on. The hormone which we've discussed several weeks and weeks ago, the hormone that will stimulate surfactant production is cortisol. And so you could administer corticosteroids to our premature baby to get them to start making surfactant on their own and then negating the need for ventilation. Okay. A couple more. We have bronchiolitis. Okay, Okay, this is when you have inflammation of the bronchioles. This becomes restrictive in terms of delivering blood oxygen all the way to the alveoli. Bronchiolitis often occurs in children. Adults sometimes develop bronchiolitis as a sidebar to COPD. Chronic bronchitis in particular can trigger bronchiolitis in adults. So if this is reoccurring in a child or in an adult, it can lead to scarring or fibrosis of the lung tissue and of the bronchial wall, which is not what you want. So how do we know that we have bronchiolitis in children? You would have dry cough, low-grade fever. Usually it's due to a bacterial infection, kind of a puffed up, hyperinflated chest, and an increase in ventilation rate. In an attempt to increase the flow of oxygen to the alveoli. The treatments for bronchiolitis. Would be things like an antibiotic if it's infectious. Corticosteroids to reduce inflammation. Other anti-inflammatories. And for children, they sometimes administer these or would also suggest humidified breathing treatments. As a mechanism to get the treatment to its final destination. Okay. Pulmonary fibrosis. All right, when something becomes fibritic, means you have scarring. You have the buildup of fibrous connective tissue in a space where it's not supposed to be. Okay, so this can occur for many, many reasons, okay? But overall, what you would have with fibrosis is a loss of compliance. So more energy is going to be required for proper ventilation of the lungs. So there are many things that can cause it. You can have scarring due to other pulmonary diseases, something like bronchiolitis. Certain autoimmune disorders contribute to lung fibrosis. Inhalation of coal dust or asbestos can contribute to pulmonary fibrosis, and incidentally, asbestos is also a risk factor for lung cancer, exposure to asbestos dust. But it also can be something called idiopathic, which basically means there's no identifiable cause. The treatment for lung fibrosis, okay. If your lungs are fibritic and becoming increasingly more fibritic, you really need a new lung, okay? But aside from that, we would want to treat with supplemental oxygen. I don't know how quickly you're getting a new lung, right? So in the meantime, we're going to give you supplemental oxygen. We're going to give you corticosteroids to improve lung function, and they give you antifibrotic drugs. I have listed one here. It's pirfenidone. Pirfenidone is a drug that has some kind of broad spectrum anti-inflammatory effects, but one of the things that it does in terms of being an antifibrotic drug is it will decrease the gene expression for genes that produce certain collagen. So overall, it'll decrease collagen production. And again, that you're approaching the problem from a different angle. You're not going to cure fibrosis with this. You're going to prevent further fibrosis from occurring by preventing the production of the protein that will help make some of that fibrous connective tissue. Okay? Really what you need is a new lung. But they don't have those for sale at Walmart just yet. Okay. Okay, two more things that I want to talk about quickly. One is pulmonary edema, and then two is acute respiratory distress syndrome. So, pulmonary edema. Okay, pulmonary edema occurs when you have fluid, excessive fluid in the lung. Now, obviously, this is going to hinder your ability for gas to be exchanged across the alveolar membrane if you have excessive amounts of fluid getting in the way. So, this can occur because of heart disease. You have a backup of fluid into the lung. Okay. Pulmonary edema would occur with left side failure. Right, so we remember from AMP2 that here's your heart, right side, left side, right? Blood is coming into the left side heart from the lung into the heart, right? And then when the left ventricle pumps, it's supposed to pump fluid out into the aorta. Well, if the left pump is failing, fluid's going to back up behind it and eventually will wind up in the lung, and you would have pulmonary edema. Okay. Pulmonary edema can also occur if someone inhales a great deal of toxic gas. So we think about people who were inhaling a lot of very toxic things in a mixture that was really unknown following 9/11, right? Those first responders right at the scene would suffer from pulmonary issues of all kinds downstream, pulmonary edema being one of them. Okay, some of the signs and symptoms, obviously you'd have difficulty breathing. You would cough up a pink sputum, like a pink frothy sputum, more work to ventilate, but you would also have very high CO2 and low oxygen. The treatment for pulmonary edema, diuretics, and that's really just about getting fluid volume decrease, vasodilators, again, to kind of relax some of those blood vessels and try to increase flow rate. And the goal there is, aside from these two, would then be to maintain adequate ventilation to the alveoli. Acute respiratory distress syndrome. So, when someone has significant damage to their alveolar capillary membranes, that's going to hinder the ability for those alveolar capillaries to have gas pass into them, and then, of course, for them to shuttle blood then out of the lungs back to the heart and into the circulatory system. One of the hallmarks of acute respiratory distress syndrome would be very, very low blood oxygen levels and massive pulmonary inflammation. So we're going to talk a little bit about the coronavirus and how it relates to some issues with lung functions, or the way that it's thought to relate to some changes in lung function. We'll do that a little bit later in our next lecture.